Good afternoon, good evening, everyone. Um, I'm Dr. Keith Crawford, Director of Clinical Trials and Patient Education at Prostate Health Education Network. I'm very excited to bring you this learning session and from our sponsor, Synchromune, and our guest speaker, which is the Chief Medical Officer uh, of Urology, for Urology at Synchromune. Now, this is a very interesting area, and to a certain extent, I go back a long way when we start talking about immunology, immunotherapy. But first, what I like to do is I like to bring on um, Dr. Andreoli. And and what we're going to do is what we try to do here when we do a learning session is I'm going to tell you, and I'm going to tell you what I told you, and I'm going to tell you again. And that's kind of how we hopefully patients, caregivers, support structures, even some of the um, primary care docs who are interested in clinical trials or docs who are interested in clinical trials learn about this new technology, new therapies that are out there or that are being researched. So, um, Jerry, Jerry, or Jerry A, or Dr. A, could you come online? How you doing, sir? Oh, you're muted.
Sorry about that.
Mhm.
I think that's
Now,
good now.
now you have kind of a spectacular training background, medical school, in a 5-year program, um, and interestingly, our paths. I was thinking our paths would have crossed when we were at Brigham, but you were there before I was, and trained in urology at Brigham, Harvard Medical School, fellowship at the NCI. So you have a different perspective. And especially if you did a research fellowship at the NCI, you probably see things from a research lens also, and just not from a clinical perspective. Now, thank you for coming, and thank you for taking your evening to just talk to patients and caregivers about this exciting clinical trial, Legion 100. And there's the technology is unique to the treatment of prostate or research for the treatment of prostate cancer. But what I wanted to do was first start with this video. And we're going to go through the video because I always, a picture's worth 1,000 words, a video's worth a million. So let's get a million words out there so the audience can get a feeling of what we're talking about. Can you?
So, this treatment involves both a device, and you can sort of see that in the lower left-hand corner there.
Mm-hmm,
It involves imaging. You saw the patient about to go into a CAT scan, but sometimes we do it under ultrasound. And
mm-hmm.
if we could stop right here. So we use the imaging to locate one of the tumor sites that a patient with metastatic prostate cancer has. And,
Okay.
and then under the imaging guidance, we place a novel type of a cryo needle. This is a needle that's capable of freezing a small part of one of the patient's tumor locations.
Oh,
And that you can see that happening right now. And that's meant to, what you see, that bluish haze is an ice ball. And what that ice ball is doing, it's not so much killing the cancer cells, because people may hear of using cryo to kill cancer cells.
right.
What we're doing here is we're using cryo to unmask certain proteins that are in the patient's cancer. And that term there, neoantigen, that's the $10 term for a protein that's specific to that individual patient's tumor. which is hidden from his immune system until we we'd use that cryo device to disrupt some of the membranes around the cancer
Hmm.
and thereby expose that neoantigen to that patient's immune system.
So let me ask you a question, Jerry. Can you um, freeze a little bit? So the question I have is so in this technique, can you go to other areas, or is it just one area that you may freeze, or do you freeze more than one area?
Oh, that's a great question. So many patients have multiple sites of metastatic prostate cancer. In fact, they may still have prostate cancer in their prostate
Hmm.
when we see them. And we know that each of those individual tumor sites are probably a little bit different from the other ones.
Hmm.
So we administer this treatment in what we call cycles. The
Hmm.
cycles are 28 days, 4 weeks apart. And so initially, we may treat a tumor that's located in the man's prostate. The next time, we may treat a tumor focus that's located in a lymph node. Third time, we may treat a separate portion of the tumor that was in his prostate, because unfortunately, some of the prostate tumors are really large, and so on down the line. If there's a metastasis of prostate cancer to the lung, we would treat that site in one of our cycles, because we know all of these tumor sites may well be different, and we need to expose all of the patient's neoantigens. Those are these tumor specific proteins to the patient's immune system to get the maximal response.
Okay, Jerry, still freeze for a second. The So be clear that you brought up an interesting point. So this approach has the ability to not just, it's not a one trick, like a silver bullet, just one shot. So you're going after it multiple cycles, 12 cycles, 10 cycles, how many cycles?
Well, up to, for the study we're doing now, it's up to 12 cycles.
So you can go
Now,
up to 12 cycles.
we had completed one uh, phase one study. This is a phase two. In the phase one study, where we planned to go as far as 12 cycles, most of the patients didn't need to go that far. After 6 cycles or so, they had complete regression of all their visible cancers. So we continue to treat them cycle after cycle until we get a complete response in their x-rays that showed
So,
that all the tumor sites have shrunk
so you, so you,
and disappeared.
so that's that. So you're talking some of the early research that's been conducted with this approach after 6 months. You're about six. Well, we said 6 cycles, so I'm kind of
Yeah,
using
that's
30
close
day
enough.
period. Yeah,
Yeah.
about 6 months. How well did it do? Or
I will say some patients had a complete response after only 3 months,
3 months?
but yeah,
Yeah.
uh, yeah.
So this.
So it's very individualized, and it depends on how heterogeneous, how different each of the different tumor focuses are in a given patient, as to how many cycles of this treatment they will need.
Mhm. So I'm gonna shelf that because I know I want to come back and ask a little bit more about this. I want to go back to this. So you have the ability with this approach to go after multiple locations, and since these neoantigens may have not neoantigens found in one location may not be in another location. So you're kind of what's going on here with these neoantigens. I think Jerry could probably start the video up some more. Let's see.
Well, over time, different prostate cancer tumor cells may become different, and we call that different clones of a
Mhm.
prostate cancer. And so different clones may metastasize to one location versus another.
Mm.
But in any event, just to pick up the video here, so after we've done what we call the partial cryolysis, in other words, the liberation, the exposing
Mhm.
of these neoantigen to the patient's immune system, we infuse into the exact same location where we did that a 4-component medication that stimulates the immune system.
So, Jerry, freeze for a second. I'm going to hold for. So you inject the multiple drugs or multiple. Well, what are you injecting? And after you freeze, you're injecting different types of drugs. But what are these different
Well,
types of drugs you're doing?
there are 4 different classes of medication
Mm-hmm.
that both stimulate the immune system
Right.
directly or stop the immune system uh, from blocking an immune response. Because as you know, Keith, better than anybody, the immune system is very complicated. It has accelerators and it has brakes. And so sometimes the reason men have metastatic prostate cancer is that their immune system is in the brake mode.
Right. Right. Right.
That there are things that stop it from killing the cancer cells. And so two of the medications in the 4-component medication are to take the brake off.
Okay. So we kick the
The other
brakes off.
2 medications are to stimulate the immune system to accelerate and rev it up even
Okay.
more than it otherwise would.
So Jerry, go ahead. Switch some more of the video. So.
So yeah, so if I'll pick it up here, what we're intending to show there is that these neoantigens and the medication that we had instilled after the small freezing are flowing very rapidly and shortly after that procedure to a lymph node. And the lymph node is where all the magic happens. A term that I've heard from you, and I think it's a lovely one, is that this is the immune factory of the body. So there's all sorts of T cells. That's generally
Yeah.
the lineage of cells that make killer cells are located in the lymph nodes. And the combination of having these neoantigens and the stimulating medications to be in the lymph nodes at the same time, at the same place, is what causes a very robust reaction to the tumor and stimulation of the immune system to produce a lot of these, what we call killer T cells. And those are the big blue cells that you see right there. And those cells then circulate out of the lymph node throughout the entire body. And they seek out and destroy, the tumors that they can recognize.
Jerry, freeze for a second. I just want the audience to kind of get an idea. So let's backtrack a little bit. So we kill the cell. Okay, we inject you inject at that site where there's damage and all these antigens, unique proteins for the cancer, and also unique proteins that may be found at that location of the cancer. Then you move it, then you flow away from that site to the lymph nodes. And a lot of people may know, sometimes when they get sick, you can kind of feel their lymph nodes swell up. So that point about the immune factory is a very important point that I wanted to bring up too. Or this regional, it's kind of like a regional location where you activate or educate all these immune cells so they can go straight back to that particular cancer. And so it's interesting just for the audience to see that, there are different locations of the cancer, but you're still may be able to create a kind of a targeted regional killing or not killing, I shouldn't say killing, but a way of attacking or going after the cancer. So Jerry, turn the video on a little bit more. I think we're almost finished.
Yeah, so this is showing those T cells, which, for better or worse, are usually referred to as killer T cells,
Hmm.
circulating throughout the entire lymphatic system and the circulatory system. And thereby, as they come in contact with tumors, you saw one just melting away there in that lung area of that diagram. Now, if we could stop there for a second, this is the novel cryo needle. If you
Hmm.
could see, the white handle, and then there's a needle extending from that, and uh, over the top of that cryo needle is a second catheter, and you see that sort of circular coiled tubing here. That is the infusion catheter.
Okay.
So you can see how the cryo needle, the tip of the cryo needle, and the site where we ultimately infuse the medication will be in the exact same location,
Wow.
because of the way the infusion catheter, is loaded over the cryo needle. And that's another way of reassuring ourselves that we're instilling this four component immunostimulatory cocktail into the spot where we performed the cryo.
So this is, it's interesting you say that this is not like a silver bullet, one shot on goal. So you had multiple shots on goal,
Correct.
up to
Right.
about 12 shots, really, from
Well,
different
that's just the
locations.
protocol. You know what? In real life, if it turns out we need more, we could do it more than just 12 times. But the protocol is, we don't really know all the details about this treatment. And For now, we're limited it to 12. Fortunately, we've seen terrific responses
Right.
in just, say, 6 months period of time. But I will say, since there's so few side effects from what we do, if it's necessary for some patients, I can envision the day where we would be allowed to administer this treatment repetitively beyond 12.
So that, I mean, so let's go back a little bit. Thank you for taking us to the video. And I think that those images can sit in the audience's heads and they can always refer back to, you know, what the tumor looked like and then the freezing of the tumor and then the additional medicine and the cells going to the lymph nodes. So that's very, very, um, very important for people to remember. So what I wanted to do, Jerry, could you show us our glossary, our key terms that you're going to hear as we continue the discussion? And I want to quickly go through those terms. Can you increase the size a little bit? Okay. So, and the audience knows that the clinical trial that we're going to talk about is the Legion 100 clinical trial. And so these are some terms that you'll hear. And clinical trial is a research study in people, okay, and it follows a plan and it checks safety and possible benefits. We're going to hear more about the Legion 100 in detail. So, but we know the Legion 100 is the investigational study. Now, this is important. It's investigational study, and it hasn't been approved yet. And we'll hear about eligibility. This is the study rules and who can participate. Um, and then informed consent. And just remember, when you participate in a clinical trial, you're always going to have an informed consent, and you can always stop at any time. Now, the Legion 100 is a phase 2 clinical trial study stage that looks at safety and dosing and some early signs of response. You're going to hear the term dose escalation, dose optimization, randomization. And then what's something I wanted to stop here, there's no placebo group. And I want to stop there. um, Dr. Andreoli, explain to me about this no placebo concept. What does that mean? What is a placebo first for our?
Well, a placebo would be uh, sugar water,
Mhm,
something that mimics the medication that's being administered by being a clear liquid of the same amount and
mhm,
instilled or injected in the same way. But one of them is the active, uh, has the active components, and the other one is just sugar water or salt water.
mhm.
And
And so
that's
this
a
is,
placebo.
and,
Yeah,
but in this case, in the Legion 100, there's no placebo. So is it? What does that
correct.
mean? Everybody gets treated?
Everybody will get the active treatment. We are testing different dosages
Hmm.
of the medication.
Hmm.
So we did a phase 1 study that we refer to that used a certain dose, and we saw some terrific responses, and we didn't see any significant side effects. In this trial, we're looking at 3 doses. The
Oh.
middle dose is the one we used in the phase 1 study.
Hmm.
Some patients will get a slightly lower dose. Other patients will get a slightly higher dose to
Hmm.
see if there's more effectiveness without any increase in side effects associated with any of the dosages.
Okay. So Jerry, let's go to the next slide. So, uh, so when we just to kind of quickly go over like cancer and the treatment words, so the words that you'll hear: metastatic castration resistant prostate cancer, and so that's the targeted population or the population that will participate in this clinical trial. Androgen deprivation therapy, ADT, and it's hormone therapy that lowers testosterone, and testosterone because testosterone may cause prostate cancer growth. Some other terms like androgen receptor pathway inhibitor, um, clear, sync T therapy, SV102. This again is an investigational drug device combo being studied. So
Right.
this is very interesting, that concept of drug device. So we'll probably hear a lot more about what that means. And we know it's you. What we've seen in the video is you freeze part of the tumor and then you inject this SV102 um, cocktail of reagents for the cancer. We're going to talk about. We've seen what the tumor freezing and the term partial lysis is. So that's freezing part of the tumor. Um, and so it breaks open the cancer and releases these, what we call proteins, but the neoproteins. And then this concept of, is it novel, this intratumoral infusion, Dr. Andreoli? Is that a novel term?
That is fairly novel. Most medications are administered either by mouth or by intravenous injection through a vein, for example. But this intratumoral infusion, we think, is very important for the effectiveness of the treatment. And I can explain it this way. And some people have asked, well, why do you call it sync T therapy? Well, it's because we're synchronizing
Hmm.
the exposure of these new patient-specific neoantigens or tumor antigens. We're exposing them, and at the same time and in the same place, we're infusing this medication, the 4-component immunostimulatory cocktail.
Hmm.
And then together they flow to one of these regional lymph nodes that
All
are
right.
nearby. And that's the immune factory. That's where the magic happens
Yeah.
because
That's
the
where the magic
antigens
happens.
and the medications are there at the same place at the same time in a relatively high dose. We can turn on the immune system. We can take off the brakes from the immune system, We can generate these what are referred to as killer T cells,
Mhm.
and then let them circulate around and do what they do.
So that's why I said, because we've looked at, because Fin Trials, we have a Find Your Trial tool, and we have to update it on a regular basis. And going through like the 600 actively recruiting prostate cancer clinical trials, this was new. That the concept is new because we kind of curate these. So that's why I was just like, wow, that is something that really reflects kind of the way the body behaves, more the natural orchestration of events when your body's fighting off cancer or an infectious disease. And then I wanted to go over to some safety words or results. And this is we overall response rate, which is ORR. And this is the percentage of patients with a complete or partial response as defined by the study rules. The complete response, um, no visible signs of cancer on a study scan, and that does not always mean it's a cure, but that's what they're seeing. Now, what's interesting is you had mentioned that there in that some of the early research was there um, a complete response in some of the early research?
Oh, yes. So, as many of the people listening to our conversation today probably know, unfortunately, bone metastases are the most common metastases from prostate cancer. And a lot of patients get bone scans, and their body may be riddled with
Hmm.
too many to count sites of bone metastases. And we had patients like that in the phase 1 study, and more than half of the patients had complete resolution, complete elimination of those visible tumor sites on serial, one after the other scans during the course of their treatment with Sync T.
So it's
More
good.
than
And
half.
these last progression-free survival, um, I don't know that some of the data that the published data was, I think you presented it either last year. It's like 17 months, 7.2 months, or something like that. And some of the folks are that we're going to have to just wait, figure out when that study is finished. That's going to be a very interesting finding to see how
Y-
long this treatment lasts. And then
Yeah,
I'll ask later, but adverse events. So any health problem during the study, even if the treatment didn't cause it, but that's one
right.
thing, but that's different than direct side effects. So we'll probably talk about these. So Jerry, you can bring down the slides and let's move on to like our quick fireside chat. And so first, one thing I wanted to ask. So to our audience, from your experience and and I'm somewhat biased because my background in immunology and immunotherapy. Um, why are new treatment options needed? What do you say when I ask that question?
Well, I will answer it on two levels. Uh, the conventional treatments for prostate cancer, androgen deprivation therapy, as you mentioned in the glossary, in other words, eliminating as much as anybody can any male related hormones, because as you said, they can stimulate the growth and spreading of prostate cancer. They work, but they work temporarily. Chemotherapy
Mhm.
works, but very modestly. Immunotherapy has been tried with taking medications intravenously,
Mhm.
and there's very few responses. And because the dosages tested were really higher than what we're instilling in our
Mhm.
series of studies, the side effect profile was really unacceptable.
Mhm.
because prostate cancer has been termed a immunologically cold tumor.
Oh, so now
And that,
you're
and
heating it up. So now you're heating it up.
well, it gets a little
Oh,
confusing
okay. So
that
yeah,
that's what stimulated the brain trust to say,
right.
well, what can we do to make
Yeah,
a immunologically cold tumor, quote unquote, hot? In other words, identifiable by the immune
yeah,
system.
yeah, yeah.
And one of the geniuses came up with, well, let's just freeze it. And that partial freezing, notwithstanding, it seems like it's a little contradictory.
Yeah, it
That's
does,
what
doesn't it?
that's
You can
what
make
does
it cold or
expose
make it
these
hot. Okay.
antigens. Yeah. And
Okay.
there are some heating modalities that theoretically could do it as well.
Hmm.
But cryo has advantages over some of the heating modalities that may be able to accomplish the same thing.
Well, yeah, yeah. So that is, let's see, you got to freeze it to heat it. So, okay,
You
I'll
got to
just
freeze
remember
it to warm it up.
warming
That's
up.
it.
Oh, that's it. That's it. So you mentioned briefly about sync T therapy, okay, about the term where it came from. Um, and and just want to be clear that the audience has to understand that we're talking, this discussion here is for educational purposes, and the research that we're talking about is not FDA approved. And so we want people just to to understand the importance of clinical trial participation, and this is a type of clinical trial. So it's interesting. The treatment is designed to teach the immune system what to look for. Is that a good way of saying it?
I think that's exactly right. That we're using cryo to unmask
Mm,
the antigens and proteins that are specific to a given man's cancer in such a way that the immune system can find them and react to them.
hmm.
It's the great unmasking.
Okay. So we you unmask, you kick the brakes off, the cancer cells,
And step on the accelerator.
and step on the accelerator. I forgot that. That's it. That adjuvant activity had to be kicked in there. Okay. So you gave us some good information about how we're making a cold region or cold tumor warmer or hotter. Now, what the but help me understand about this education, or how you activate the immune system. You talked about these killer T cells. So you got the dendritic cells, these cells that mop up these, and then they give it to the T cell to educate them. It's interesting about how, could you better help us understand about how you get these T cells to remember um, the cancer, or the, even if you're saying this, like the cancer location really may be different, and if you have bone metastasis versus the cancer that was found in the prostate. Is that correct? Am I
That's correct. And that is why we would like to treat a diverse uh, uh, group of tumors in an individual patient, because we know they all may have slightly different neoantigens associated with them. And so that's why the initial treatments may be directed towards a large amount of cancer that's in the prostate, and the subsequent treatments may be to lymph nodes that has cancer in it, or a lung metastasis that has cancer, or cancer that's at another site, because we want to maximize the immune system's learning. We want that man's immune system to learn what his cancer looks like.
Mhm.
And
Okay.
and now that we're going over that, this reminds me of what I think is a very important point here,
Okay.
and that is this treatment works best in patients who have a strong immune system.
Right.
One of the things in the back of my mind, and probably yours, is, if a patient with metastatic castrate-resistant prostate cancer gets treated first with hormone therapy, that may have a few minor effects on the immune system. But then
Right.
if he then gets chemotherapy, the chemo can have a much more significant impact on his immune system, can actually harm
Weaken.
his immune system.
Yeah. Yes.
And then there are other forms of radiation that he can receive, either by Pluvicto, which is a common lutetium form of radiation right now, that also seems to weaken the immune system. So, in me thinking out loud, and I'd love to hear what you think about it, I would say to maximize the response to an immunotherapeutic treatment like this,
Hmm.
it would be best to take a patient before he's
Right.
received some of these other treatments that will weaken his immune system.
It's interesting you say that because I told you I'm biased because this clinical trial is almost the way the body, the immune system normally works. Yeah, you're not freezing it, but what happens is you have a localized immune response around the cancer because if cancer cells exist, and the immune system is always surveying the body and during natural, but the tumor's escaped and now it increases in size and may move away from the primary location, but it's almost the way the immune system naturally works. So now I agree with you. I like the approach, and hopefully, with more and more success, we could move earlier to a point where maybe when a person's diagnosed, and you can hopefully be able to treat them with this concept, this design, this 1-2 punch, you know, earliest possible before you start treatments that weaken the immune system. Now you brought up if we go, you brought up one of those like the radioligand therapies. Now,
That's
when
right.
you start
Yeah.
talking about Legion 100, and you have a person who has metastatic castration-resistant prostate cancer, um, there's this little focal point. Are they able to participate in the clinical trial if they have been treated with some of these radio pharmaceuticals?
Yes. Yes, they can. Um, but it could be one or the other. In other words, a man could have received chemo
Hmm.
or he could have received the radioligand. But we really worry that if a man has received both of them
Oh,
and failed both of them, that he's not eligible for this study.
so one or the other. So you can have.
There you go. One or the other, chemo or radioligand therapy.
Mhm. So what about, okay, so say for example, what is defined as, so you have to have metastatic disease, so because that means that the cancer has to move away from the primary source, the prostate, away. So we have that. And but if they moved away, do they have to fail on just one next generation hormone therapy or multiple, or before they can be eligible for this for your Legion 100?
Yeah, they could they will all have failed hormone therapy or ADT, and strategies that eliminate as much as we reasonably can of male hormones in the body, and that would define them as having metastatic and castrate resistant prostate cancer. Now, at that point, when they fulfill the criteria for metastatic castrate resistant prostate cancer, they could receive this as their very, very first line of treatment for
Mhm.
that phase of
Okay.
their disease.
And
Yeah.
in the way that the preliminary data, your earlier research was extremely positive, and what were were there progression-free survival or not? Would how would you describe it? It was almost 13 months or 12 months where the disease hasn't recurred.
Well, at a median follow-up of 17.4 months, I think it was,
Mm-hmm.
and this was presented at the main cancer meeting, ASCO, a year ago.
Mm-hmm.
At a median follow-up of 17.2 months, we had not seen the median overall survival. In other words, more than half of the patients were alive, and I'll tell you, it's a lot more than half of the patients were alive.
Okay.
And that's a little bit of a difficult statistic to get your
Mm-hmm.
head around. But that's all we can say right now, and we're continuing to monitor the patients who were in the phase 1 study, and hope to be updating the
Okay.
survival with an additional 12 months over the 17 months of follow-up to see how many patients remain alive.
Okay. So let's go back a little bit. So let me ask you a question. Metastatic castration resistant, that's the diagnosis. You're telling the audience that this is a pretty excellent, novel clinical trial that people should consider because it's not something that's toxic or or it may have side effects because we haven't talked about the side effects, but I'm thinking that the side effects that we hear about immunotherapies like cytokine storms are not something that a patient experiences, or has that been something that's come up or disclosed?
No, not at all. And the adverse events that occurred in this study, thinking way back to your glossary slide, uh, the people who had good eyes and could read fast noted that there were five categories of adverse events ranging in severity from one being very, very mild all the way up to five, in other words, dying from the treatment. 95% of the adverse events were either grade 1, very, very
Mm-hmm.
mild,
Yeah.
or
Right.
grade 2, short term, and reversed during the therapy. So it is a very well tolerated therapy. And as regards the tolerability of the therapy, one thing I didn't mention at the beginning of the video, and I meant
Mhm.
to,
Right.
was that, oh boy, we're sticking needles into a tumor, and some men may be thinking this is some major operation. It isn't. It's generally done as an outpatient under
Mm-hmm.
sedation, not always requiring full, anesthesia. And patients go home the very same day. The freezing and the installation of the medication together take less than 1 hour to do. So it's not very intrusive, to a patient's daily life. It's not like chemotherapy with repetitive returns and very severe side effects associated with the chemotherapy. Not at all.
Yeah. And so that's very important. One of the things that's very important about this clinical trial, the side effect issue. Let's go back. Um, there was a question about side effects, which we've addressed, right? The placebo. So it's important for everybody to understand that everybody's going to be treated if you participate in the clinical trial with the active ingredient. Do you get three different, does a person get a low or medium or high dose, or do they get all the different dosages? How do you decide on who gets um, that dose if you participate in a clinical trial?
The first patients who enrolled in the study, received the low dose, and then the next group received the middle dose, and the
Mhm,
next group after that received the highest dose that we're
mhm,
testing.
mhm.
And uh, I'm not at liberty to say, but the strategy is to observe those patients and see what, if any, side effects they had. And
Mhm.
then we would select the two doses
Right,
that uh, uh, had the lowest side effect profile,
right.
and then the additional patients in the study, the next it's 50 odd, 56 odd patients will receive one of those two doses.
Okay, all right. So the question is, and this is a question. So, what is the class of is this? What is the class of therapy that we would call it? Just this is an immunotherapy, but you got a
It,
device and then
it's
you have
it's a device based, immunotherapy. I don't know it. It's so novel. I
right.
don't
Yeah,
think there
that's
is
what it
a
is.
specific category, for it.
So another question is, what tests must I complete before the study team decides whether I qualify?
Okay. So first we, have conversations. We want to get all the details of the patient's prostate cancer journey. What treatments has he received? Uh, when was he diagnosed? How's his PSA going? What sort of metastases does he have now? And once we determine that he qualifies because he has metastatic
Right, right, right.
castrate-resistant prostate cancer, then to enter the study, we're going to get some imaging or X-ray studies.
Mhm,
If his prostate is still in, some men may have had their prostate removed before. We would get an MRI scan of the prostate. We would get a CAT scan. We would get a bone scan,
mhm,
and we would also get a what's called a PSMA PET scan.
mhm.
Those are the tests that look and can identify metastases throughout the entire body.
Okay.
And then once we have that imaging, the whole group of imaging studies that we were just talking about, we sit down with the patient's physicians, and we decide which uh, tumor site we're going to treat first.
Mhm,
Then we see how he does 1 month later, or 28 days to be exact. We may repeat imaging depending which site we treated first, and then rediscuss with the patient's treating team of physicians which is going to be site number two that we're going to treat, and that dialogue continues, for the duration of that patient's participation in this study.
mhm. Okay. So another question, and this is something that you briefly mentioned about the strength of the immune system. And so the question here is, how do you know if the patient has a strong immune system?
Hmm. You know more about that than I do now. You're playing coy with me.
No,
But I
no,
would
I'm just
say
saying.
for the study,
You're my
we
guest.
look
Okay.
we
I was, I,
we look at their various uh, components of the immune system, the lymphocyte count and other counts that we can see on what are fairly routine blood tests that
okay.
all the patients you would ordinarily get. Yeah.
Okay. All right. Okay. So, um, the there was there was this question. It was interesting. Can all sites of metastatic disease be reached by the needle? Bone, liver, lung.
Good question. good question. The answer is we think so. We haven't yet had a scenario where we couldn't reach a particular tumor site. Uh, we are developing new needles
Mm-hmm.
that can deal specifically with bone metastases
Mm-hmm.
because
Right.
it's and we I really don't know what to say about uh, how much pain, discomfort, type of anesthesia may be necessary to insert a needle through bone into
Right.
a metastatic site. We know that when we go after the soft, we call them soft tissue sites, like the prostate, the lymph nodes, and lung metastases, we can do that under very mild sedation.
Mm-hmm.
Uh, but as we develop that, uh, uh, more we'll give you the news,
Okay.
down the road.
Okay. So that's good. So now, what I wanted to do is this. So we're approaching the end of our learning session. But if you, after all that we've talked about, and this is kind of like the lightning round. So you got, if you want, you know, patients, caregivers, loved ones who are here who recognize that clinical trials are part of your treatment options, and we know it's clinical research, and they have a loved one who has metastatic disease, what would be the key takeaways from today's learning session that you would want someone to understand or walk away with?
Well, I spent my career counseling patients about entering clinical trials so we could collectively advance our knowledge and improve the science. This is a particularly good study for that because it's completely novel and because it's completely new in its approach.
Hmm.
We're being very, very cautious. We're
Okay.
doing a lot of testing of these patients. And as I said, there's a lot of back and forth between those of us involved in designing and performing the study with the patient's treating physicians,
Hmm.
so
Okay.
that I think the care that patients who participate in this study will get is probably going to be more careful and more thoughtful just
Hmm.
because of the large number of people who are weighing in, if you would, each 28 days, looking at all of the x-rays and blood
Right.
test results and making these treatment decisions than it might be if a poor patient is seeing, just one overly busy medical oncologist or urologist somewhere who doesn't have access to a, forgive me for using the term, a brain trust of people who
Right.
can look at things differently.
Hmm. That's it's amazing because you think about it, because I see this clinical trial which is generating all this information and thinking ahead that you don't have to have these sophisticated academic medical centers. And it's almost a treatment that can easily be in the community setting at a community hospital.
Darn tootin'. Yes, sir.
And so it's like,
Absolutely.
so it's kind of like, I don't mean it disrespectfully, like the blue collar, the average person, the average American could have access to this and go back, be treated early, because you envision that, something like that. I know it's a research, and I know I don't want to get my hand slapped, but I'm just saying, I'm thinking it's so positive to hear about something like this that will ultimately, the way it's going, be available for not only folks in major metropolitan areas who have access to some more expensive treatment options, but just for people in rural America, people in southern areas of the South who don't have these major academic centers.
Right.
So
Yeah,
what?
the study is open at quite a number of different sites around the country, and we have a lot of geographical diversity
Mhm.
in the sites that are currently performing or will soon be able to perform this study with us.
So Jerry, can you put up the poll, our post session poll, so we can kind of get some information about how well we performed today? Well, and I will still we can still chat um, um, a little bit more. So metastatic castration resistant is the diagnosis. We have a device and a treatment combination. Um, we have we touched upon the concept of placebo, but in this case, everyone will get the treatment. They may have a different dose, but they'll get the treatment. We talked about, previous research findings is very exciting. So what is that? Are you writing a paper or what are you guys doing about this? Because so we can hear, we can't wait to get to the end of the novel. So when can we expect something more information about how well the the phase one clinical trial did?
Well, we presented that at the main cancer meeting about a year ago. We presented it at the main uh, urology cancer meeting within the last 6 or 8 months. And we're in the process of, as I mentioned, uh, monitoring the group of men who were treated in the phase one study to get longer follow up, to get the overall survival and another year's worth of follow up from the initial data lock,
Mhm.
and are writing that paper. And when we have this uh, later analysis with longer follow up, we'll
Mhm.
start presenting that again at the scientific meetings.
So we're just going to have to sit on the edge of our chairs and just wait.
Hey, that's what makes science exciting,
Yes,
you
it
know?
does make it exciting, and we can't wait. So we have now think about this. It's a cutting edge technology, right? Now, cost. I didn't ask you. So cutting edge
Mm.
technology is almost like concierge, the way you support and monitor the patients on a regular basis, like a concierge medicine. Um, is there a cost associated with this?
Not to the patient uh, at all. Uh,
Mhm.
uh, some of a small portion of what we do in the study would be considered standard of care that
Mhm.
the patient with metastatic castrate-resistant prostate cancer would receive, whether or not he was in this particular study. But a lot of the things that we do are paid for by the company and by our donors and such.
And so we'll be like, say for example, the locations. We'll be able to, if people are interested, if you go to fintrials.com and look up the clinical trial, and we'll have a video up, so we'll have more information that's available. Um, and then some folks, this is an interesting question. So we know we got a ringer in here when they start talking about regulatory T cells. So I'm like, oh,
That's
I
you,
see.
baby.
That's
Keith,
it. So it's like,
you got to help me out
yeah,
with
this
that.
is. I said, have you thought of getting rid of regulatory T cells initially to strengthen the immune response? I mean, that's an interesting concept, but a little bit more complicated because now you're gonna have to throw something in to block the regulatory T cells. But we'll leave that for another discussion. Uh,
Hmm.
but let's just get the good results where we're keeping our fingers crossed, which which will be coming down when you publish this paper. Um, and I think that was Jerry. How are we with going with the poll? Are we okay? So I think, are we ready to proceed? Okay. So the first question, um, I understand that Legion 100 is a phase 2 clinical trial for men with metastatic castration-resistant prostate cancer. 93% of those in attendance said yes. No one said no. And then 7% said not sure. I said, I understand that the therapy being evaluated, SYNC-T therapy, SV102, is an investigational intra-tumor infusion being studied in the Legion 100 trial, 100%. Now, you know that's excellent because rarely do you get 100% and then you throw in intra-tumor infusion and people understand. So
I think it was the video that did it.
I think so. The video, I told you, it's a million words. If
Million
everybody
words.
can just see it, yeah, yeah, that's an excellent video. Number three, I understand that there is no control placebo group, and all the patients in the Region 100 Phase 2 trial will receive the investigational SYNC-T therapy, SV102. Oh, that's another 100% walked away. The next question, number four, I understand that SYNC-T therapy, S102, is a combination drug and device procedure. 96% said yes, and then 4% said somewhat. We're going to have to work on that person. You guys can give us a call and we can go over this. All right. Now, number five, based on your learning today, would you consider
Mm.
participating in or referring someone to the Legion 100 clinical trial for metastatic castration-resistant prostate cancer? 81% said yes, 19% said unsure, but no one said no. So that's good. So based on number six, based on the information presented today, I better understand SYNC-T, what SYNC-T is, and how the therapy can potentially help men with advanced prostate cancer. 85% said excellent, and 15% said they good, the good understanding. I understand that participation may involve including treatments every 4 weeks for up to 12 cycles. 92% said yes, and 8% said not sure. Next question, number 8. I understand what participation may involve, including managing imaging for each cycle and treatment response assessed every 12 weeks. 92% said yes, 4% said no, and 4% said not sure. Okay, next question. Did the learning session help you better understand clinical trials? 80% said yes, and
Mm.
20% said somewhat. Number 10, will you now consider participating in a clinical trial? 64% said yes, and 36% said, I'm not sure. Are you a potential candidate for clinical trial presented in this learning session? 24% said yes, 52% said no, and 24% said not sure. So again, we'll have the video up. You can always go to fintrials.com and look at our patient summaries. But if all else fails, you can give us a call and we can help walk you through this clinical trial. So again, I wanted to thank you, Dr. Andreoli, about taking your time in this evening to kind of walk through the Legion 100 clinical trial and help us better understand this research, this clinical trial, this phase 2A clinical trial that has surprising, exciting early research studies. And is there anything before we close that you would want to leave the audience with today?
Yeah, I mean, as I said, I spent a lot of my career designing and performing clinical trials. And the people I admire most are the patients and their families because, they put their trust in the system that we have, and they journey back and forth, to the hospital and endure
Mhm.
a large battery of tests. And I have to say that I think the tenacity that patients show
Mhm.
and the willingness to participate and their willingness to help expand our knowledge base and how to beat prostate cancer is the most impressive thing that I've observed in my 40 plus years.
Okay. All right. So that's very powerful. That's a very powerful statement. So I want to thank you for taking your time. I want to thank our sponsor, Synchromune, and I want to thank all of those folks in the audience who took their evening to spend time with us today to learn more about this exciting clinical research. Thank you very much. Have a great evening.